Welcome to the Central Ray podcast. My name is Ryan Ross and I will be your host as we talk about all things radiography. Here we will focus on X-ray from my somewhat unique perspective as a former surgical imager, compliance coordinator, manager and now an educator. Please like and subscribe to make sure you do not miss out on any future episodes and conversations with surgeons, medical physicists and industry leaders. Please feel free to email me at ask@thecentralray.podcast with your questions for upcoming topics or to provide feedback on the content. Now, enjoy the show.
If you have surgeons that have that little confidence in the ability of the people that are being provided for them to do these surgeries for, well, what does that say? They don't have the expertise, they don't have the knowledge, and they wind up having a bad experience because they've walked into a case where the surgeon requires expertise, time is of the essence, and they truly don't know what to do. They're floundering, and it's not really their fault.
And thank you for joining me today on the Central Ray podcast. And if this is your first time tuning in, then welcome. I hope you enjoy what you hear here. Please go ahead and check out some of the previous episodes also. Today, I am talking with a very good friend of mine, Walter Klocko. He has been a surgical radiographer for over 20 years at Vanderbilt in the Level 1 Trauma Center, and he's been a technologist for over 40 years. So he brings so much knowledge to the discussion. We spend most of this discussion talking about C-arm and how it really needs to be viewed in its own separate modality or an advanced practice role. So I hope you get some good information from this and enjoy the conversation. Hi, Walter. How are you?
Hey, I'm good. How are you doing today?
Very good. So thanks so much for taking the time to talk to me today. Obviously, I feel that you're someone that shares my same passion on C-arm. So I just want to hear your opinion on a few things. But let's go ahead and start with just a little bit of background on you. So how long have you been a rad tech and how did you get started in the field?
Right. So I've been a rad tech since 83. So I guess we're looking at 42 years.
Wow.
And during that time, I probably spent the first 20 years doing all the basics of radiology, private practice, and some larger institutions, a lot of those being here in Nashville. And then, of course, the last 22 years, I've been primarily in OR radiology, C-arms, portables, and whatnot.
So how did you end up transitioning from routine into there? Did you transition within that facility, or did you hire into an OR position?
Throughout my career, I've always done OR, primarily because most of the people at the institutions never wanted to go up to the OR. But then when I reached employment at Vanderbilt, I was a weekend tech doing 216s, and again at Vanderbilt nobody wanted the OR position, so I found myself just being the one that because I liked OR, they allowed to go up there, and they liked the fact that I was covering it, and so that became my position.
And don't you find that a really well-defined line of those that love the OR and then those that absolutely hate it? It's a very few people that don't mind it. You either seem to be all in with it or all against it.
Oh, absolutely. And personally, I attribute that to the fact that if you do not have a good comfort level in the OR, and if you've not spent any adequate time there to understand what's going on, it can be a very scary environment and can consequently, I think, most people that I've known shy away for it for those reasons exactly.
Well, that probably brings me on to one of my next points, and definitely something to talk about. So when you transitioned over, or when you started in the OR, you know, one of the common complaints that I see and hear just now is that there's not any real form of instruction, there's no real preparation. So was it different back when you started out? Like, did anyone show you the cases, like from radiology, from that side of things?
Oh, no. Well, my start was different a little bit. Back in the day, I went to LSU in Shreveport. Their radiology program there was a 2-year program, and it was very similar to the way the programs are run today, but the difference being they had the students spend 3 months in the OR. Now, the other difference being is in my dinosaur days, C-arms had not been developed yet. CAT scan actually had just come into place. So in that institution's OR radiography, you were utilizing 1 or 2 portable machines to do orthopedic cases, to take multiple views, and you were actually wet developing, you were hand dipping your films. And so the requirements, the skill level was a lot greater. There are a lot many more factors, and you just had to be on. So we luckily got 3 months of experience versus what they get today.
So even when I started in the OR, so I went X-ray school in 2011. My second year placement, I got a lot of OR experience, mostly in pain management. But even then, as a student, it was just, well, you're just going to go in and shoot an AP, and then if they want something different, they'll tell you. I never really felt as though I got guidance from the instructors on explaining the movements or the fine details. From where I am now, the fine details of what we're looking at. And it's kind of interesting that I still see that same lack of formal education exist. Why do you think it's never progressed beyond that, just get in there and figure it out, try and survive?
You know, I've always questioned, like I'm sure you do, the schools. Typically what we see are the students coming in, they get a quote-unquote 2-week rotation, which I think probably realistically translates into maybe 4 days each week in the OR, and typically most institutions may not have a clinical instructor in the OR. I know at Vanderbilt, I'm available and I love working with the students, and there have been times where I get a student that I feel is engaged and interested. I've had many students that I'll let them watch me do a femoral nail or tibial nail or some of the more simple cases, and after watching me, I'll walk them through it. But again, backing up to I think what you were originally wanting to know is in my day, no, there was no instruction. There never has been, to my knowledge, and all of my knowledge has come at the expense of in the private practice, just trying to struggle through private practice physicians that aren't really interested in telling you anything. There's nobody there. You just figure it out on the fly. But then at Vanderbilt, the wonderful thing that I've encountered at Vanderbilt, and like I said, I've been there like 22 years, but when I came there, since it's a teaching institution, there is a degree of you have the ability to, you have residents, you have various people that as long as you're interested and engaged, they will help you along. But I guess back to your original question, I've never really seen any formal application of instruction in OR radiography.
Yeah, and from several conversations I've had with other people at other places across the country, they also mention where there are some surgeons basically have a no students allowed policy.
Right, yeah.
And I find that crazy, but that kind of leads me to, I don't know if there's sufficient trust in the technologists from the surgeons, because it's very hard to have a teaching conversation when you're in an intricate case.
True.
And obviously much of the experience that we share is in that orthopedic trauma, which are very complex procedures. But you have to give up and learn some of those. But the pressure doesn't really allow for that type of conversation. And I guess with volume as well, when that case is done, you don't have a chance to really reflect on it because it's on to the next one.
Right.
So how much do you feel that the surgeons are really selling themselves short by not allowing that investment to train that next generation?
Probably a great degree. I think, in my experience with the surgeons at Vanderbilt, there is some desire to allow teaching, but as you said, on the fly, it's very hard when their role is they kind of have enough on their plate instructing residents, and then of course they've got a certain amount of trauma they need to put through, so you can't really slow things down for a lot of factors, for patient safety, for the fact that maybe you have 6 or 8 trauma cases you need to get through. I think they're just caught in a difficult situation. I know a lot of the surgeons would love to see the degree of expertise that, say, you and I have in the OR, but the ability to get it is hard for multiple reasons.
Yeah, and it really, a lot of that just comes from the experience. But what I find is when students come in, a lot of that conversation that I was referencing earlier, it's really on the basic principles of how to move the machine,
right?
How to boom the arm in, how to tilt. That conversation shouldn't take place in the OR.
No.
That should be taught, or that should be common knowledge well in advance of entering into those rooms, even if it's just a routine. So it's a hard environment to get at because, speaking from the education side of things, we have 18 months or 2 years to teach everything that we know and everything that we're required to demonstrate. And a lot of schools don't really have that resource to invest in it. But I think also there's, as a percentage of technologists, there's only a small percentage have that perspective of what surgical imaging requires.
Right.
So the knowledge need, I don't think, is present that as college faculty can really impart that level of knowledge within that same level of time. So it's a very, very hard place. It's almost as if the X-ray schools were trying to cram too much in too short a period, and we don't really see the downstream impact because the OR needs highly trained people, but we also are helping to create an environment where the student or the new graduate is underprepared. And if you're underprepared, given our current staffing shortages, you walk in the room, or you're supposed to be the imaging expert, but you are underprepared, you're probably going to have a negative environment or a negative outcome with a surgeon getting frustrated. And that spirals into a resistance to ever go back into the OR. I'm sure. Is that something you've seen before, or?
Oh, without a doubt. As I was mentioning earlier, once a radiographer has a bad experience like that, I know very few people that like to come up to the OR for that very reason. It takes, well, an example, as I said before, I was doing OR work for 20 years before I got to Vanderbilt, and I thought I was pretty much, hot stuff.
Yeah.
And when I got to Vanderbilt, what I found was I had a good deal of expertise, but nothing near the level that was required at a level 1 trauma center, and it really took me 6 good months of paying attention, inquiring, and being a part of the team. And of course, they're very receptive to that and helped me along. But it took me, already at the level I was at, a good 6 months to get to a comfort level where I felt like I was operating as an equal part of the team.
Yeah, I'm very, very similar. So I worked at a regional community hospital for about 2 years, straight out of school. They had 6 ORs, and we would do it on a rotation. So once every 6 weeks for a week, I would get in there, and I couldn't wait for the next time I would get in. I just loved the environment, or maybe the development of skill, or the impact that I felt I was making in those cases.
Right.
And most of that work was really done with spine doctors. And similarly, I thought when I moved to Nashville and Vanderbilt, I took the OR job thinking, okay, well, not a lot of people want to work in OR. I'm pretty decent on that. I'll go do that. And then my first ever observation day was a cancer patient getting a preventative femoral nail. So, from those patients,
Right.
they're not lying in a standard position.
No.
Their leg is draping off, it's hanging down 20 degrees, and the tech that I was training with, their pager goes, and it's like, buddy, I can either leave you here trying this femoral nail, or you can go do a vascular run in some OR the other side of the hospital. And that was like day one.
Right.
I had never even seen a femoral nail, and talk about struggle, but it was that perseverance of try to get over it. But I will say that tech explained the situation to the doctor, and it was a resident, and he said, I can tell this one's going to be a good one, so don't be mean.
Right.
And they basically talked me through it. But 2 years of working in these cases, and the first case I observed at Vanderbilt was completely foreign to me. So there's a level, and I think coming back to the staffing shortages, there's a higher influx of new graduates, especially in an area like Vanderbilt where you have one or two level 1 trauma centers that have that. There's more entry-level graduates finding their way into those situations, and it's not fair.
Right.
It's not fair to the surgeon, definitely not fair to the patient, and it's not fair to the tech. And as we mentioned, the schools don't really have that time allowance or resource allowance. So there has to be an in-between somewhere. Maybe it's an appreciation that onboarding of C-arm takes a little bit longer than 2 hours,
Oh, no doubt.
And I think that's one of the things that's lacking, because there's not much in the way of educational resources outside of it either. I can't think of any textbooks. I know we had many conversations about the industry's desperate for one. We have slightly differing opinions. I come from the geometry side, and you're very much on the case side.
Right.
The knowledge that you have, you've forgotten way more than I could ever take in. I was just a very quick learner with the geometry of the situation, so I think that's how I was able to progress relatively quickly. But just that level of appreciation, you can't expect students or new hires to experience that.
Well, I think one of the huge problems and why there's a need for a formal, whether it's modality or formal instruction that is much longer, is especially with ortho trauma, but with surgical radiography, such a big part of what makes a good or a skilled radiographer in the OR is the ability to, several abilities. One is just to manipulate the C-arm and to operate it, to understand the various locks, to understand every image, every angle, everything that you can ilk out of it, because in surgery, the patient's draped, and we all know our anatomy. We all know a lateral and an AP and this and that. But the problem is you don't see anything, and every shot you take is an indication of where you are. And within that, you have surgeons that have manipulated terrible fractures they're trying to manipulate it into a reasonable reduction. There's multiple clamps and instruments that, as you well know, some of them are very large. And when you're in that arena manipulating this big machine, sometimes the room between the image intensifier and the instruments and the fracture are minuscule. I mean, sometimes you've only got a centimeter to work with, and you're applying multiple images in pelvic work. It can get very complex where you're doing obturator outlets and inlets and all these projections, and so it really requires you to be a master at manipulating a huge piece of equipment, maintaining sterility, not upsetting reduction, and working around multiple people. I mean, sometimes there may be as many as 7 or 8 sterile people in the field. So there's just a lot to do, and I really think it requires more than being thrust into on-the-job training.
Yeah, and I think the experience buys confidence, and I think that's probably what really sets technologists like you and I, obviously from new hires, etc. But you have a certain level of confidence which gains respect as a valid team member in the OR.
Right.
And as you said earlier, like 6 months, it probably took somewhere in that same region for me to feel comfortable, and I think probably that comfort came out in the exterior as confidence.
Oh, without a doubt.
I always preach to my students, like, you have to be seen as the imaging expert. Mm-hmm. Because when that surgeon calls for x-ray and you walk in the door, they expect an RTR that is capable and comfortable with the manipulation of this machine. But we go in there without the training of, well, when I oblique over the top, how does my anatomy move? If I come in 2 degrees off my perfect lateral approach and now I come up for my AP, why has my anatomy rotated on the image? All of that can be taught well in advance. So at least there's a geometrical awareness that you now feel I can make logical corrections.
Right.
Because when you have someone like the surgeon relying on us to get an image, and then we clearly look as though we're guessing, and then we're not even sure if that's the right thing, it doesn't buy confidence from the surgeon.
No. And consequently, and you know this as well, if we're not giving them a perfect image, starting points, there are so many factors to what they do in every aspect of orthopedic surgery that if our views are not appropriate, they're either having to tell us to adjust our view, or in the case of residents who sometimes they're learning as well. Yeah. So sometimes, and you and I both know, there's many times where the resident is doing the surgery, the attending's out of the room, which all is appropriate, but the resident doesn't have enough knowledge to realize the view isn't the right view. They get a starting point that's off, and they have problems, and that's all because of an inadequate radiographer running a C-arm.
Well, one of the examples I give on that is if we're trying to line up a perfect circle,
right,
and we don't have it in the center of the screen,
right.
If you're working with that resident on the weekend or whenever it might be, and all they're looking for is a perfect circle, but if that shows in the 10 o'clock position and it's not center, and the resident then goes, oh, that's great, keep it right there. From my perspective now, you're using the term the imaging expert, I should have enough confidence to say to that surgeon, let me put that in the center of the screen because we're not actually centered.
Right.
No, that's a perfect circle. No, but this is a divergent beam. The screw won't locate where you need it. Give me 2 more shots and we'll line that up.
Right.
You can't expect that from someone with less than 6 months experience because you're still trying to figure the whole thing out, and no one has that level of, or the feeling that they have that open voice.
Right.
But I know that when you cross that bridge of being trusted, your surgeons, your attendings, they expect it.
Exactly.
Because you're there as a care team, and that I remember one time where I became vocal. And the surgeon, I always kind of joke with the students because they would say, the surgeon said, I didn't appreciate it. Well, in medical terms, that just means they didn't observe it. They didn't see it.
Right.
Because they're like, they didn't appreciate it? Well, that was rude. It's learn your medical terminology. You have to learn how to speak in these environments as well. Mm-hmm. But it was a section of a fracture that they were trying to put the locking screw in, but it wasn't getting a bite. And it was actually pushing the fragment further away. Yeah. And I'm like, doctor, you're pushing on that fragment, it might break. Well, they didn't appreciate that. They got a bigger screw, they still weren't getting a bite. Well, guess what? Now the bigger screw was putting more pressure on it, and, the attending walks in the room and goes, hey, you're pushing on that fragment. And the fellow, to their credit, said, Ryan said that. Yeah. So you didn't listen to the tech that's done 200 of these cases.
Exactly.
How many have you done? So in many instances, I'm sure, especially you having 22 years experience, would you care to take a guess at how many pelvis cases you've done?
Oh, goodness. I couldn't, but that's one of the things that attracted me and I find extremely rewarding in that modality is that I feel like in surgical radiography, you are more a part of a focused team, and you start your day, you see something from beginning to end, and you were a part of expediting it, of a good outcome. I mean, it's extremely rewarding, and you know this as well. When you have built the level of skill and confidence we have, it's almost embarrassing the amount of respect that you get, and that's that's better than money to me.
Yeah, and I think that's one of the reasons why I feel so impassioned about this, because we're talking about something I basically done 10 years ago, mm-hmm. but I can see such the need, and talking about the respect, I ran into a surgeon, or I called up a surgeon, and because they appreciated my skill, I got an hour of their time to talk about this.
Right.
For free. Mm-hmm. And the surgeons, they want better. They want us to succeed in these roles. And I think they share that pain, but they're not in the radiology loop or the radiography loop mm-hmm. to fix it. And I'm like, you two need to talk. Because for you really change the industry, I think, our governing body, if you look at the ARRT, it's like we need to open up and listen to all of the stakeholders in our career paths. And surgery is a very valid career path because a word we've mentioned both already is we love the environment, we love the cases, we love the teamwork. And the surgeons love us being there because they know that their patient is getting higher level outcomes or more efficient surgery, whatever it is. And I just don't think that the orthopedic realm, from where we spend most of our time, or you spend mm-hmm. almost most of your time, is appreciated, using that word again, by our field.
Right.
Because the discussions I've had with managers in the past, they would always term it, well, this is an entry-level position, so in terms of compensation, it's exactly where it's supposed to be. But I think if you ask that orthopedic surgeon, they would easily justify and validate, they would pay you extra themselves in many instances.
Right.
Because they get it. And how can we make the world see the importance of that C-arm tech and why that level of skill is so important to the patient and the surgery team?
I think it would take, like you said earlier, maybe conversations with some of the surgeons. I mean, because I hate saying things because they sound a little egotistical, but you know how it feels to walk into the room.
Fact is fact, and sometimes we speak in black and white, and it just is.
But you know how it is to walk into the room and I mean, sometimes people clap. You can just see the relief on their faces when you walk into a room of a complex case, or the times where you finished a case and they got another one coming up, and they're like, Ryan or Walter, could you please come back? Because it's no exaggeration that a skilled, qualified radiographer in the OR literally can shave 15 to 30 minutes off of a case, and that helps the patient. Yeah. That expedites more cases to be done in complex situations where you have patients that are very critical. You just simply can't have someone floundering around wasting time, and then the frustration level rises. And I kind of compare it sometimes to a golf game. It's like when you're in a groove, and that's referring to the team. You've got a team that knows this procedure. They do it. It's like it's this smooth, enjoyable game. Everybody knows the moves ahead of time, versus when you have someone in there that, unfortunately, by no fault of their own, they've only had a couple weeks of quote-unquote experience in the OR, but they're plunged into this scenario, and then all of a sudden they slow that game down to a frustrating comedy of errors sometimes,
And picking up a little bit on that point, we've spent most of our focus talking about students and new hires, but I've seen situations where technologists with decades of experience beyond me, they come to this environment and they treat it with not really a disrespect, but they don't appreciate the skill that is in there, and they go into those cases and it just seems as if they've never operated a C-arm before. And I'm like, how can you be 25 years in working OR and just not having... I can't fathom why that exists, because you have people that can work it for 10 years and still don't have that level of skill. And I think that comes from loving what you do.
True. I would agree with that, but I would also say sometimes, and I hate to say this, but people can say anything. They say what they want on their resume. And when they quote unquote say they've got OR experience, again, I would relate that back to myself. After 20 years, I thought I had a lot of OR experience, and I did, and I was pretty good. But walking into Vanderbilt, I was not at that level. And
I mean, I've been driving a car for 25, 30 years, but I'm not going to go ride the Daytona 500 next month,
Right, yeah.
So I get it. The experience of doing something doesn't always buy you that skill. And that kind of brings us on to, another passion piece of mine, I guess, when I was talking to a surgeon about this, they felt that in this current age where there's a lot of travel technologists, they're being given contracts primarily because they have OR experience on their resume.
Right.
And they're saying as soon as they pull into the field, it's like, I can tell by the way they drive that machine in, this is going to be a rough case.
Right.
And coming from the surgeons, they would like to see some form of advanced credential or a national certification, which now basically sets a bar or a threshold that if you have OR experience, this bar should be a comfort to say, we know what we're getting.
Right.
And I think that would be a fantastic addition as a career path, because there's, I want to say there's not very many people like you that stick with it financially, because we're still paid as radiographer. We don't have that type of pay structure in the field.
Oh, exactly.
But I've observed a couple of other technologists that have passed the age of retirement, but they still work because they love it. and the surgeons love them. And just as we alluded to, there's a little bit of an ego scratch in there, and it's not fair to keep people in the role just because they love it. So I think as a career path, we've both shared our department with some phenomenal techs that have moved on because they needed that $5 an hour.
Oh, exactly.
And I'm like, the department doesn't realize how much extra it is now costing, because that case now takes an hour extra longer. So the downstream impact of losing a tech for $5 or $10, it's pennies compared to the additional anesthesia costs, just the extra risk to the patient for the anesthesia or for the hypothermia in these complex cases. Mm-hmm. I also heard instances where treatment plans had to be altered because the technologist couldn't image efficiently to get the original plan done within the time frame of the patient's injury. Especially if you have a traumatic brain injury patient, which oftentimes you do in orthopedic trauma. These motor vehicle incidents, there's a lot of times head trauma involved as well. So if that patient can't stay under anesthesia for any more than 2 hours, it takes a very special technologist to get in there and basically do the job without talking, because you're so in tune with the process.
Right. It's funny that you mentioned not talking. One of our attending physicians, pelvic physician that trained under Chip Rout, he developed a horrible case of laryngitis one day, and we literally did an entire percutaneous complex pelvic case. The whole team, not a word was uttered. I mean, nothing. It was just done, like just orchestrated, because everybody knew what they were doing. And
it's like the perfect word that you said, the orchestration. You said orchestrated. And when you talk about all these robotic devices or the three-dimensional navigational C-arms, etc., that are automated, they can remember their positions. Mm-hmm. I've done some of those cases as well, where you just speak in silence, or there's music on, you just want to listen to the music and enjoy it. And that, for the surgeon, I would suppose, is almost their sense of the ideal case, because they get the imaging when they want it. They get the view just the way they want it, just the way it was. So everything that they need is basically automated. And even better, you now have a team of humans that you share the moment with.
Right, yeah.
So that automation is completely possible within a team when you have competent people in their role. And that's one of the things I try and impart on my students, because I can't expect them to learn everything in the 20 weeks that we kind of set aside for them. But I want them to have the potential to experience it.
Right.
So if I can hit 2 or 3 of those students to actually persevere with that initial 6 months to get into that environment. And, I'm very fortunate enough that we have an internship program where we can send some of the better students over to Vanderbilt as a 5-week internship of sorts. And they all come back saying they love it. They love being the part of the team. It's like everything you explained, that we get it. But the pay is like, they're starting me off at whatever that is. And in my head, I'm thinking, they're paying $15 an hour more than when I started. Mm-hmm.
Right.
In terms of pay for the role, it's better than it ever was. But in terms of pay for the skill, I think that's really where a lot of the benefit to radiographers would come from that advanced certification.
And on that same line, I think there's enough in surgical radiography where a course, an advanced certification. I mean, we could talk for hours on just within the realm of orthopedic trauma. You should know when you were speaking in terms of automation and expertise. What gets you to that level is understanding how a femoral nail is done from starting point to perfect circles. Each thing is not unlike when we're in school for radiography. When you have to learn, you have to have 20 checkoffs on knees. You have to have 50 checkoffs on femurs. Well, with OR radiography, unfortunately, because they only get 2 weeks exposure, what do they get? You have to do one competency on what, something like a urological procedure, which is like a well-disciplined orangutan could manipulate that. But it just, without beating a dead horse or at the risk of, it needs an advanced certification. It needs a schooling level that provides that knowledge.
And because when I went through school, and obviously I would say I had a lot of C-arm experience as a student. I done a lot of AP and lateral spine work, and that 2 years. But when I went into those cases with the level of doctors that we were talking about, a level 1 or trauma site, I mean, you have nationally and internationally recognized physicians that you're working with.
Right.
And I come through for a lateral, and it was like, I asked for a lateral. And I'm like, in my head, I'm like, that looks like every other lateral I ever shot. It's like, I need those end plates lined up.
Exactly.
Like, I've never heard that before, Dora. I'm sorry. What do we need? And you could see that frustration, but I had several surgeons when I was first starting out. They would get ready to blow their top, but then they would take a breath and go, okay, I need you to add the wag. Okay, go the other way. See how now we have a single line? That's what we're looking for.
Right.
And guess what they got the next time they asked for a lateral?
That exact thing.
And that to me was always the criteria for my job, was reproducibility. And again, that comes back from the geometry. When you're doing those SI screws, if you come in for that pelvis, or if you come in for that AP, and you see any form of deviation from 12 to 6 of the spine, and I've spoken about this on several other episodes and to other people, is when the surgeon says, coming back to the confidence of the tech, being the expert, if the surgeon says, rotate that image, make it straight up and down for me.
Right.
The correct response from us should be, let me adjust my base, doctor. No, rotate the image. That won't fix the geometry, doctor. Trust me, let me fix my base. Because when I come from my inlet, I'm no longer rotating the anatomy. So when we have the confidence of that knowledge, geometrically, we now sound educated to the surgeon, and they get it.
Right.
And like, great, awesome, yeah, thank you.
It's just like being able to explain to a resident that's learning how to do SI screws that when they're using their instrument to initially draw their lines, if you simply help them understand, I'll usually say, if you let me come through a lateral and we get our ISO center first and we get everything set up, I can give you your 3 views and nothing will have to move and they'll be perfect every time.
Yep. Because there's so many different angulation possibilities on the C-arm, the technologist has to be so keenly aware of that. For me, I'm always on the geometry side of things, but they really have to be so focused on that, because if they don't get it right at the start, that's going to be a really tough case for everyone.
Right, no doubt.
And unfortunately, I'm also speaking from some experience where when I started out, it was tough. They were rough cases.
Yeah.
And you'd mentioned the ISO center. I have a slightly different opinion on that based on C-arm, but I remember doing pedicle screws once, and I came in with the radiology mentality, the ALARA principle from our aspect. And again, this is where lack of knowledge on my part. I was new, never done these cases before, and they're challenging. But we were doing the case, and the surgeon would place the pedicle screw. Okay, coming in for AP, and I would lower my machine down, get as clean an image as I could, get it nice and close.
Right.
Okay, raise your machine. He would come in, drill the hand, and then, okay, lower the C-arm down again, because I'm trying to minimize my dose. I added hours onto that case, because you're probably talking about 100 exposures on a multi-level pedicle screw.
Right.
And I'm working with the radiology principles of reducing my distance, minimizing my OID. I'm doing a great job in terms of dose for everyone. But I didn't realize I was adding more risk, because the time that it was taking me, the 8-10 seconds to lower the machine each time, no one ever told me not to. The contrary was, everyone told me that I should do that, because that was the ALARA principle. And I think the understanding of, I know what ALARA is, but to me in the OR, ALARA is time. We want this patient in and out of here as quick as possible, and if that means having 8-inch OID, if I can now shoot 20 images in the same time it would take to shoot 2 the other way, ain't no one complaining about that.
Right, yeah.
You might get the odd surgeon here or there, but usually they're single shot doctors. So it's also about understanding your environment. Know when if I'm doing finals, I'm getting that as close, I'm maximizing my field of view. But again, that radiography principle is like, well, the magnification, all that matters to me is what is in the center of that screen.
Right.
We shouldn't have a field of view for a lot of the cases we're talking about, because we're based on precision, and that precision comes from the central ray. So if we are taking anything from the periphery, we're not doing a good job. So that's having the confidence again as that tech to understand, because it's intimidating to work with surgeons, especially ones you don't know. But as soon as you demonstrate confidence, they learn really quickly that you're good. Right. And you don't get any attitude, because we wouldn't work a lot with the tumor doctors. You would see them, a couple of them very, very rarely. But as I alluded to earlier with the femoral nail, the patients are never in prime position for a nail. So you have to get creative.
Oh, without a doubt.
And there was some surgeons, or I don't even know if I know their name, and I had to break the knuckle, so I'm using the smart scan, I'm kind of this weird thing, and the surgeon's like, whoa, what are you doing? I'm like, to get your AP doctor, I need to make this move. I've never seen that before. What are you doing? It's like, give me one shot, doctor. But because you have the confidence and you've done it before, and then you shoot it, it then becomes the normal, and you train the surgeons that accept my skill. Focus on the image I'm putting up on the screen. Don't you pay any attention to this machine, because I can barely keep track of it, but don't look at it. So they get confused. And I remember when I started using the whole knuckle maneuver, there were some surgeons I still couldn't keep happy. But the other ones, where I was doing acetabulum, they saw that I could have that one position and get all the views and make no other adjustments. So from the efficiency perspective, just do what you do. And they would never even look at my machine. They just look up at the screen. They don't take their eyes off of anything, because what they're looking at, they trust my image as being exactly their eyes and perspective.
And it's funny you talk about trust, and trust has to be earned, but I think earlier you were asking about I forget what the question was, but what I was thinking about is there's a particular spine surgeon, and alluding to the degree or the type of operators he's been working with in the past, he would have them come in with the C-arm and literally draw lines on the floor to mark once he was doing percutaneous pedicle screws with a tube system, and he would, because of their lack of understanding or expertise, he would guide them in, have them get exactly where he wanted to be, where he was working, and he would make them lock the C-arm in place and make marks on the floor, and it was not to be moved because he was so worried that he wouldn't get the same user get what he needed. And this particular technologist needed a break or was on break, and so I went in to take over the procedure. At the time, they weren't utilizing the C-arm, but by God, it was locked in place, marks drawn. And anesthesia needed to get to the patient, need to work on some lines or something. And I needed to move it. And I started to move it, and the surgeon absolutely freaked out. He was like, no, you can't move that. And I said, it's okay. I've done these before. I can get it back to the same exact image. But we laugh, but it kind of illustrates that if you have surgeons that have that little confidence in the ability of the people that are being provided for them to do these surgeries for, well, what does that say about?
We're talking about those cases being tough, but from an imaging perspective, they're not.
No.
So the fact that you have a surgeon freaking out about, now I'm on this side, it's like, imaging-wise, that's a fairly straightforward routine. It ain't a multi-fracture pelvis.
Right.
It ain't a 4-piece acetabulum.
It's about the simplest thing we do.
Yeah, and when you know the markers is like, I maybe need one extra exposure in that entire case. With the students, we don't work with laser because I want their eyes to be adjusted to manipulations on the screen. And the laser can move, the laser can travel. If you're on the newer machines, when you come through for a lateral, the weight of the laser pulls it off by 2 degrees. So I'm like, you never trust the laser. The laser's a comfort blanket for the surgeon.
It's a luxury.
You get your first image for free, and then everything after that is pure skill on your part. That's it. And you will have less repeats when you're trying to manipulate the image rather than manipulate the laser placement.
Right.
Because, when you're doing SI screws, your inlet and outlet, the laser only indicates where the laser's entering the drape. Doesn't really show you where it's entering the patient, and drapes move. So that little crease that you were keeping track of, guess what? Once the drill goes down or the elbow rubs up against it, your landmarks are all now gone. So, coming up to that image fulcrum idea, which I prefer rather than the isocenter for the C-arm, that's kind of like key to understanding that efficiency,
right?
And those cases,
But that gets all thrown to hell too, because typically when they start the case, they never started at their operative height, so the height changes and the fulcrum changes and all that.
But again, when you're locked in on the case, they raise the table height, I raise my C-arm.
You go with them, exactly.
And I think all that comes to trust, because to me, I used to love it when we would do the antegrade nails, and they're putting in the distal locking screws proximally, and you're at all sorts of weird angles because it was a knee start, so they're
right.
So you're already tilted, and you line up your perfect circle. It's beautiful, and then say, "Can you check the depth?" Well, your lateral's never at a fulcrum point, so you have to move your machine all the way down.
Right.
They shoot the lateral, and they're happy. All right, come up, show me the other circle. I just moved everything. That used to be the most satisfying thing for me, is because I would, me with my pencil, I would write everything, and I would come right back up to my original position, and then I knew how far I would have to travel north, the 25 millimeters, to get the separation, and then, boom. one-time perfect circle.
Right.
And I'm like, nice shit. And in my head, I'm like, this is just logical knowledge.
Exactly.
There's no luck in this. And I'm like, it doesn't even really make me happy anymore because this is my job. This is how I'm supposed to do it.
It's planning. It's knowing what you're supposed to do.
Yeah. And to me, it's like, that's completely teachable.
Right. Agreed.
And it's teachable. The geometry is teachable early. The experience you can't teach. Experience might get you a little bit of a shortcut on it, but until you start seeing those cases
in advance, you could train students almost like any other exam they do. You could pick a tibial nail, a femoral nail. There's at least probably 10 orthopedic surgeries that you could walk them through like we used to do with our steps on the steps to doing a knee or this or that. You could do the same thing with a femoral nail. You get the starting point. You got the opening reamer. You need to be here for that, and then you go down to the fracture. You introduce the fracture. There's probably 8 or 10 operative steps that if a student prior to seeing that case or being exposed to it, if they at least know that. They could even have a guide, and that way they'd be spending their day with me or whomever else in the OR. They'd already have a preliminary understanding, just like the residents that are learning. You don't walk into there not knowing diddly.
Well, I don't have it with me, but I don't know if you've seen the little training blog that I
haven't.
So as soon as we're done, I'll go ahead and show you. So what I've done with that is I put in a lot of the common angles from the cases that we would do. So your acetabulums, your SI screws, the distal locking measurements. So when I'm training students, I can have them replicate those motions.
Right.
And depending on how I position the fulcrum, they either have to slide their base to reproduce their inlet and outlet. But it kind of it's twofold. It builds up a muscle memory.
Right.
And then also builds up, because it uses perfect circle channels. So if they're not 100% precise, it's very clear.
Yeah.
And it almost overtrains them, but I don't really think there is such a thing, because it just makes you even more comfortable. Because if the technologist is thinking too much about the movement of the machine, they're not in the case.
Right.
So being able to have all the mechanical part taken care of, now they can actually focus on the variations of this case, i.e. this fracture is different from every other one that I've seen. Every fracture is different, but pretty much every acetabulum has the same views. Every SI case has the same screws. So it's been able to get that mechanical knowledge down so that the muscle memory is there.
Right.
But now having the anatomical and geometric awareness to vary the new situations that they find themselves in.
Right.
And I think that would shortcut a lot. And I also think it would encourage more people to stick around in the OR, because if the surgeons start to see, they actually know how to move the machine. It's not great, but you know what? They're actually moving it pretty well. They seem comfortable. Because I always think if you know how to manipulate that central ray or just move the machine, the surgeon will be a whole lot more forgiving of you because you haven't seen their case before.
Oh, no doubt.
But if you say, go ahead and tilt that for me, and I don't know which way to tilt it, or I continuously tilt it the wrong way, or which one's tilt? Maybe not want to say that out loud. But I think that's currently where people are being let in the OR, where they don't have that base knowledge.
Right.
And I've heard stories and I've seen stories. Fortunately, I've never been the brunt of those stories. But I couldn't imagine the feeling of that happening in a case where you're just belittled so much. I've had to replace techs in cases. Oh,
no doubt, and that's always horrible. Embarrassing. I've had that happen to me too, where the physician comes up to me and says, Walter, I need you in room 12, and I've even had some of my supervisors, when I would try to diplomatically communicate that to them and have them say, kind of tactfully, hey, Walter's going to swap you out or something here, where I'll have a supervisor that is kind of like, no, the doctor's going to have to take what they've got. And that's kind of a hard situation, too, because you're like, well, why are we giving them suboptimal and forcing that when he clearly wants, a certain level of expertise?
That would also be another justification for the advanced credentialing, because now the surgeon, rather than attaching a name to a request, which it currently is,
right,
they can actually, just as the on their sheet, they have the supply sheet. The name escapes me.
Yeah,
but you know what I mean. The list of everything that they need.
Yeah.
Then they can highlight on there advanced practice radiographer.
Exactly.
Just as they would do, I need
FA, I need
and that is like, at least now there's a bar of some comfort. There's still always going to be preference within that.
Right.
But it's not fair. I used to hate being in other rooms and seeing those cases happening when I wasn't in there, because I always felt that the surgeon was struggling, or if I was stuck in another case that I just couldn't leave that was, let's say, basic, and someone else is having to answer that call, you couldn't really speak up and go, hey, if you want to come in here and relieve me, I can go ahead and get that.
Right.
Even though that's probably a better scenario for everyone, because the tech that's responding is probably sweating buckets going,
well, it's funny because that exact scenario, again, I'm trying to sound egotistical, happens to me all the time, and most of the times the tech that I'm replacing is not offended. I always feel it's an uncomfortable feeling, but it's one that, bottom line, when I do it, I feel good because I know there's going to be a better outcome. The case is going to be shorter. The physician's going to be happy, and it's just all around better. So what? I'm curious. What will it take to get to where we want to be in terms of having this become a specialty or a certification?
Well, I think it comes down to, obviously the ASRT has this campaign of Be Seen, which is a fantastic campaign making our jobs more visible to everyone, those that we work alongside and to the public, etc. as well. But one of the analogies I've always used is it's like the end of Shrek with the donkey who's shouting up and saying, pick me, pick me. I think my job is to perform when I'm given the opportunity, but for this to kind of stick, you need to talk to who do we impact most, and that's going to be the surgeons. So I think the validation needs to come from the orthopedic surgeons that we know, because typically they are the more complex cases that require us.
Right.
And I think if our governing bodies listened to them and their struggles, or how much they truly value the technologists that they work with day in, day out, and have taken years to develop relationships with, they would see that their frustration for when that technologist leaves, because financially they just have to, because the career path is a dead end, I think then they would listen, because it happened with RAs. Radiologists said, we're overwhelmed. Is there something that we can train up and create a career path for radiographers who enjoy fluoroscopy? Yeah, we can train them how to administer barium and watch an esophagram and then come to us. I think something along that same line of having the surgeons validate and say, these qualified or these highly skilled techs save us 25-30% in case time. And there was a recent post I saw on LinkedIn where it was one surgeon saying, I don't think people realize the long-term risk that we put ourselves under, with radiation dose and with anesthesia gas, etc. So when you have a technologist who doesn't understand that same risk and takes 100% more exposures per case, and that's a modest estimate, or prolongs that case time and makes that surgeon stay in that room for an extra 2 hours every day, we're increasing risk to others other than the patient. The patient's there for a reason. They are broken. They need fixed. The surgeon, they are there by choice, and we can protect them more by being more efficient and employing efficient training, and creating a system to encourage the good ones to stick around longer, if not until retirement. Because I also feel that when I was starting out, I worked a whole lot harder just by manipulating the C-arm.
Oh, no doubt.
Than when I got to this almost zen instance of, find the fulcrum, and now the machine is so light.
Right.
Because I don't have to move the entire thing. So I think you can work incredibly more complex, but with less effort as well.
Yeah, it's almost like you find the ergonomics of, as silly as it sounds, there is a definite art and ergonomics to each case, and you learn how to set up for things so that, and that's another thing that, orthopedic trauma is so satisfying to me in many aspects. In that it's always a challenge, it's the same, but it's always different, and I kind of get my nut, being finding ways to be efficient, less movements, maximum, bang for your buck, and it's almost like I love it because it's like a chess game to me.
Yeah.
The procedure, what they're doing, there's instruments that fix this, and you use this at this point, and it's the same thing with the C-arm. When you've done it enough, you've perfected your art to the degree that every movement is just the only movement you need, and it gets the exact outcome. And it's no longer work. It
becomes a dance.
Yeah, it's play.
Really
it's fun.
Yeah, it's absolutely a dance, and and I find it ironic that we both come from a music background.
Oh yeah,
which we never even touched upon.
We're both drummers.
Yeah. But I think we understand, and I've said this before in previous episodes, that to improve in music, you have to play all the time. And also to get better technically, you have to practice.
And you got to push your limits too.
And that's why when I went to Vanderbilt, I wanted in those hardest cases.
Yeah.
I couldn't wait for a day that you were off. I couldn't wait for a day that John was off because I was stepping up.
Right.
And I think that eagerness got seen, but then when I got a taste of it, I would grab a C-arm. And I remember you walking in OR 12, I think it was, and I was in there practicing. I had a Phantom, and I was...
Right, yeah.
And I'm like, that's what you do as a musician to get better. So that's why that was the mentality I had on C-arm, was let me get an obturator outlet with my knuckle broken, and then take the C-arm out of the field, and then role play the surgeon saying, can you come in and show me? I need to tighten that screw.
Right.
And then can I reproduce? So that's kind of what I was going for. So as you say with that chess game, but I also wanted to know how the game would finish.
Right.
I wanted to test myself of, can I get the outcome that I expect? And telling the students, the exposure is not for us. I already know what it looks like.
Yeah.
I'm doing this to share to the world. I don't need the x-ray. I know what it looks like.
Right, exactly.
So that was always the challenge for me. And for some people that are listening, when we talk about these cases, we could be talking about 1,400 exposures.
Yeah, easily, yeah.
And if you do the simple math on that, if you're operating in low-dose fluoroscopy mode, then you get 2 exposures per fluoroscopy second. We're probably looking at 12, 14-minute cases, on polytraumas, complex ortho.
That's not out of the ordinary.
Yeah, you get a tough acetabulum. 12 minutes, you're up past 1,000 exposures, you know? So, yeah, 1,440 on the math on that one. So if we can reduce that, and that's us shooting good.
Right.
You know? It's all the exposures that don't get saved, you know? And a lot of this is very hard to get real-world metrics to justify it, because every fracture is completely different. But I think it's pretty clear that if you're doing the case, or I'm doing the case, or the highly skilled tech is doing the case, we shot a lot less than the others.
Oh, no doubt.
You know, so that's another impact that I hope to have using my little training phantom, is that it's a standardized object that we can now use as a measurement tool of, okay, let's see if we can increase efficiency. Let's see if we can see a difference between Tech A and Tech B. Yes, we can. So what is Tech A doing differently that we can now help train Tech B and actually give Tech B a method of improvement?
Right.
Which doesn't exist, because our method of improvement is just, we'll try and do better tomorrow than I done yesterday. Well, how? Because tomorrow's fracture is different. I don't have a benchmark.
But there's basics that, and you know this as well as I do, and the geometry, what I love and talking about, there's so many secrets, there's so many tip-offs that if you know what you're doing, you see along the case that you use as a guide that novice operators don't even know to look for. And when you think in terms of every nail and every plate has a geometry, they have holes, they have endpoints, and as you're working in one place and you make an exposure, it gives you information sometimes about your next move, by virtue of the circles or the ends of the nails.
Yeah.
If they're parallel, you know that when you swing up to do your proximal interlocks on a femoral nail, you know you're going to have a perfect circle before you even take your shot. So as you're working, you log all these things. And
absolutely. That's what I was going to say. Like, the amount of times that you shoot a perfect circle first time, and then the room with strangers is like, wow, you got lucky or whatever. Like,
it's like, I knew it was going to be perfect before I shot it.
I know. I was like, we're 15 minutes into the case. I've shot this area 50 times already.
Exactly.
I know exactly where it is.
Exactly.
I was like, I can see your jig. I know that I need to be 15 degrees rolled over from it. So as you say, all these landmarks that exist. But I think the ultimate outcome of all of this is really just an understanding and an appreciation, kind of to round off on that word, an appreciation of the skill that is not seen in the world of radiology. You know, and we are housed in the world of radiology. They're our paymaster, if you like.
Right.
And I think that conversation between the OR, whether it be ortho or whoever, if they are able to delineate that level of skill in a far more articulate manner than we could, because it's like everything else. When a surgeon speaks, everyone listens.
Right.
When a technologist speaks, it's just it's just a cricket. No one really is an annoyance in the background. So I think when you get the people that really feel the poor work most, I think that's I don't mean to sound derogatory on that, because when I say poor work, that's the truth. But that poor work is not the technologist's fault.
Right.
You know, I always say it's the industry is letting everyone down because we don't have the education, we don't have the requirement of training, we don't have that benchmark expectation. So I think just that readjustment hopefully can be, accepted as a dire need. You know, when the Joint Commission came out with that fluoroscopy dose tracking, everyone was all up in arms about dose reduction and ALARA. And from my perspective, having been in the OR for years, and likewise, I'm looking at it going, you have no idea the amount of unnecessary exposure that occurs on mobile C-arm.
Right.
Because no one is looking.
Right.
you know. So, but listen, Walter, I feel as though I've taken up way too much more of your time.
No, not at all.
We might even come around and fill in some gaps when we do this again. You know, every time we talk, it's for hours. But listen, I appreciate your time so much. You have more knowledge in your big toe than my entire body, so I appreciate what you shared. And you know, I enjoy being your friend. So thank you so much for
Well, thank you. It's always a pleasure. And, you know, I've said it many times, I miss your presence at Vanderbilt. I mean, it was always wonderful sharing the workload, and you do just tremendous work. But you're doing tremendous work here, and I hope it continues and goes in the direction you're headed toward.
Can you believe we made it through over an hour and 15 minutes and never used a cuss word?
Well, I did say nut, I think.
Well, there you have it, folks. I hope you enjoyed that conversation. Walter's an absolute gem of a guy. Please go ahead, check out my website, thecentralraypodcast.com. And remember, I have the YouTube channel where I demonstrate some C-arm videos and also demonstrate on how to use my C-arm training tool, the Ross C-arm training Phantom. So I hope you enjoy checking that out, and I look forward to seeing you on the next one. Take care.